There is no audio. Ajay,
Not for this video.
I can't hear anything.
Yeah, I know that, but you can figure it out from the video only.
Okay. I just asked whether any audio is there. I thought only I am the one. I'm not.
Yeah,
Fine,
okay,
fine,
okay.
fine. Yeah.
Everybody is done. Yes, I'm done.
So I think you guys got a little idea about the SMA. So now we can come into the drug. So the drug is a nusinersen. So the brand name is Spinraza, and then it's a survival motor neuron directed antisense oligonucleotide indicated for the treatment of only SMA in pediatric and adult patients. It's the first approved drug in the treatment of spinal muscular atrophy, and is also the one of the most expensive drug in the world. Like it cost around like 75,000 euros in Europe, and then $125,000 in USA, and 4,80,000 in India. That is the cost per injection. And so the mechanism of action. So it's been designed to attach to the SMN2 gene, which only works in this SMA because there's an absence of SMN1 gene. So as a result, the SMN2 gene starts producing high amount of the SMN protein. So this SMN protein will regain the most motor function, which has been lost in the this spinal muscular atrophy disease. So it will like treat the disease. So dosing information. It's administered only through intrathecally, that is in this say spinal cord, and under the direction of healthcare professional experienced in performing the lumbar punctures. So recommended dose is 12 mg, that is 5 ml per administration. First Spinraza treatment is given is 4 loading doses. The first 3 loading doses will be administered at 14 days interval. Like after giving the first dose, this will wait for 14 days and then give the second dose. That should be done for the 3 doses. After that, then they will wait for the 30 days and they'll give the fourth loading dose. And after that, the maintenance dose is provided administered every 4 months. So what should we do if we miss a dose? So if a loading dose is delayed or missed, we should administer it as soon as possible with at least 14 days between doses and continue dosing as prescribed. If a maintenance dose is delayed or missed, we should administer it as soon as possible and continue dosing every 4 months. So there are like some criteria for preparation and administration of this drug. So these are the preparation thing. Then the Spinraza is used for only intrathecal, and then each vial is intended for single dose only. So we should store the Spinraza in the carton in a refrigerator until the time of use. Then when the time of the use comes, we should take out the Spinraza outside the refrigerator and keep it under the room temperature. We should not use external heat sources. So we should inspect the spine raja for particulate matter and discoloration prior to the administration. We should not administer spine raja if visible particulates are observed or if the liquid in vial is discolored. The use of external filter is not required. We should withdraw 12 mg of spine raja from the single dose vial into a syringe and discard unused content of the vial. Administer spine raja within 4 hours of removal from vial. So these are the criteria for the administration. We should consider sedation as indicated by the clinical condition of the patient, because lumbar puncture can be like a little painful. So we should consider ultrasound or other imaging techniques to guide intrathecal administration of spine raja, particularly in younger patients. So prior to administration, remove 5 ml of cerebrospinal fluid, and then we should give the administered spine raja as an intrathecal bolus injection over 1 to 3 minutes using a spinal anesthesia needle. We should not administer spine raja in areas of the skin where there are signs of infection or inflammation. So these are the pharmacokinetic. In absorption, intrathecal injection is uh, directly goes into this cerebrospinal fluid, which allows the nusinersen to be distributed from the CSF to the target central nervous system. Its median plasma Tmax values range from 1.7 to 6 hours. So distribution is like it's distributed within the CNS and peripheral tissue, such as skeletal muscle, liver, and kidney. Metabolism is it's metabolized via exonuclease mediated hydrolysis. It doesn't gets metabolized, or it doesn't get anything with the cytochrome proteins. And then excretion is its half-life is estimated to be around 135 to 177 days in cerebrospinal fluid and 63 to 87 days in plasma. So the primary route of elimination is likely by urinary excretion for nusinersen. At 24 hours, only 0.5% of the administered dose was recovered in the urine. So these are the major ADR. The thrombocytopenia and renal toxicity are the major ADR for this drug. And then other ADR which were seen in the trials were like upper and lower respiratory tract infection, ear infections, constipation, decreased weight, and there is a risk that the growth of the child and infant might be stunted. And then the teething. So contraindication, there were no contraindication found. And also for the administration in pregnant and lactating women, there are no sufficient, like there is no even like single human trial conducted for that. And the trial which were conducted on the mice, the drug was given subcutaneously, and it showed like long-term neurobehavioral impairment. So it's like recommended not to be used in the pregnancy until and unless like it is very necessary. So monitoring parameters are like platelet count for, of course, for the areas of thrombocytopenia, coagulation test, prothrombin time, activated partial APTT, and then quantitative spot urine protein testing. So for the patient counseling point, we should inform the doctor if we have like kidney problems, which are like unable to pass urine, blood in the urine, or change in amount of urine passed, or weight gain. If we see the following signs like bleeding, like vomiting blood, or vomit that looks like coffee grounds, coughing of blood in the urine, black, red or tarry stools, bleeding from the gums, abnormal vaginal bleeding, bruises without a region or that gets bigger, or any severe or persistent bleeding. And the urinary tract infection like blood in the urine, burning or painful urination, passing a lot of urine, fever, lower abdominal pain or pelvic pain, and then other symptoms like fall, chills, sputum discoloration, shortness of breath, cough, ear pain, and then significant reaction, signs of significant reaction like wheezing, chest tightness, fever, itching, bad cough, blue skin color, seizures, swelling of face, lips, tongue, or throat. Thank you. So any questions?
This
Anybody have any question?
nusinersen, yeah. So this nusinersen also causes hyponatremia, severe hyponatremia. You missed that.
That I couldn't found anywhere, like the hyponatremia was not included.
It causes hyponatremia, and like for 14 months, salt supplementation should be done.
Okay, that was really nice addition. Electrolyte imbalance.
Sir?
Any other electrolyte imbalance you had written, Ajay?
No,
included?
sir. There are no any other electrolyte
Okay.
imbalance.
Only sodium. That
Only sodium.
okay.
Yes, Sarad wants to ask something.
Why shouldn't we administer to the area of infection or inflammation? Does it increase the bioavailability or something?
Sorry, I didn't get you.
Why should we administer? Why shouldn't we administer to the area of infection or inflammation? You had said it in the administration slide.
But because it actually like increases the chance of infection. Because when the skin is already infected, you cannot administer it, right?
Okay. Inflammation also we can't administer.
Yeah, we cannot do it.
No, definitely already it's injured and inflamed. There is high chance of one of the like local injury chance will be there for this kind of intrathecal